To overcome the coronavirus, there's plenty of agreement about the need for a maximum access to vaccines as soon as possible. But making that happen takes more than a limited number of mega sites and mobilization of the military. To share some ideas on what's needed in Boston, especially for populations disproportionately affected by COVID-19, is a longtime leader in community health and a regular contributor to the Dorchester Reporter, Bill Walczak. Bill, thank you very much for joining us again.
Pleased to be here. Thank you, Chris.
Bill, I read your latest column about the vaccines, and you did some math, and basically what I think you were saying is that at the rate we're going, we're not going to get this out to everybody until something like the middle of 2023. Is that a fair way to calculate this?
Well, trend analysis is usually a fair way to calculate the future. I mean, things have happened since I did that math. We have opened up Gillette, which is theoretically able to do 5,000 doses per day, and we will be opening up Fenway. But what I tried to do is I tried to take a look at how many people we have in Massachusetts, and since right now you need 2 doses to get to be able to become immunized, how long will it take to get 2 doses into every person's arm? And the answer to that, based on Gillette, even adding Gillette in at full capacity starting now, is that we wouldn't have it until June or July of next year. And so we clearly needed to do more. And the governor did say that we were going to be opening up 165 sites, local sites, and 5 new mega sites and stuff like that. My view is that we really need to look backwards. One of the recommendations I have is let's take a look backwards from, if our goal is to get 2 shots in every person's arm by September, how many shots do we need to do on a daily basis or a weekly basis? And the answer on a weekly basis is 420,000 per week. 420,000 doses per week will get us to September. Meaning that 100% of Massachusetts will have 2 shots by then. But if we want June, it's actually higher than that. So, what does it take in order to get that done? And that's, I think, a very important element that somebody in the media, and I'm happy to do it because it's not that complicated. It's really basic math, needs to follow this and figure out how we doing, because almost everybody I have talked to about this thinks that we'll all be vaccinated sometime in the spring. And in order to get to that point, you need to have a hell of a lot of infrastructure in place that is not in place currently, although it could be in place because we certainly have the capacity as a state to do it.
Well, one thing we've done before is give a lot of flu shots to people, even at supermarkets and pharmacy chains. So what's the difference here? Because I know one thing about a coronavirus vaccine is you got to wait 15 minutes after you get that shot.
That's a major consideration because if you get a flu shot, you just get the flu shot and you walk off. But now you got to have somebody monitoring everybody that gets that flu shot. So you can do it very quickly on a flu shot, but on coronavirus, there's a delay. And that means that it does make more sense to have mega sites because then you could have people that are, you can have people drive in, say over Bayside, the Bayside site that's going to be, all the Dorchester Bay City. Right now, it's just a big open space. You could put tents up there. You could have cars that drive up. You can give them the shots, and they could drive over to a place where they get monitored for 15 minutes or whatever, and then drive off. That's something that could happen with that. But that does not negate the whole notion of needing all sorts of local sites because local sites are where people typically get these types of things. So health centers, primary care sites, pharmacies, and all that. So, but we need. Like for instance, Chuck Jones from Neponset was health center and Harbor Health Services was telling me that it makes it difficult to have efficiency in giving shots for coronavirus because they need places, waiting rooms. They need large enough waiting rooms to be able to accommodate people after they get their shots. So that's like kind of a consideration, but it shouldn't mean that we have to wait until next year before everyone's vaccinated. We just need an array of sites that makes sense for Massachusetts and all the different populations that we have.
I understand that you can't have people just walking up willy-nilly to this or that location and expecting to get something done pretty quickly. But on the other hand, what about the vetting of eligibility that we're putting people through here, at least in Massachusetts? Is there too much of that maybe?
Yes, definitely. I think one of the problems that we've had is inflexibility around, phase one, part B, part C, all this kind of stuff. The Boston Globe this morning has an article about Northeastern University having an additional 2,000 doses and wanted to just start using them to get doses in people's arms, and was told to hold back on it because they wanted to make sure that they were following uh, the the phases. That doesn't make any sense to me. I mean, the reality is hundreds of thousands of people nationally are getting this uh, uh, very this coronavirus, COVID, on a weekly basis. Hundreds of thousands of people, and thousands are dying. We know that it's a preventive disease. And if it's a preventive disease because of this vaccine, we need to do everything in our power to get as many vaccines into people's arms as quickly as possible. We cannot lose an opportunity with a patient to not do it. So we need to get it out quickly as possible because otherwise more people are going to die. So
I want to
yeah.
check on you about that, because about the sense of urgency, because the past couple of weeks in Massachusetts, the level of new infections has gone down. The positive test rates are going down. So right now we might be getting a bit more complacent, but off on the horizon, I see these articles about variants that are, they're spreading more. They might even be more deadly. How does that factor into what we should feel about what to do here?
Well, I mean, I listened to this show called This Week in Virology, which I highly recommend to anybody who wants to kind of get deep into the weeds of this. And right now, they believe that the variants are able to be handled. But if we allow the virus to continue with hundreds of thousands of infections, we give that much more opportunity for the virus to mutate. So the quicker we can get these into arms, there'll be less likely mutations of it. Although, frankly, it's a worldwide phenomenon, so that may be the case. But I've also heard for instance, the mRNA RNA doses are like, aiming 1,000 guns at the virus. That there's a lot of capacity within the doses of Moderna and Pfizer to be able to handle these small mutations in the virus. So needing to get it out quickly is also part of a process in which we have more people that are not going to be spreading the virus as quickly, because it's not going to be going across the population as quickly. So I would say that it's still really, really important to get these doses in arms as quickly as possible and try to put a lid on it so that we have more control over it as it spreads in the future, even if these mutations continue to develop.
There was a poll done locally not too long ago showing that only about 80% of the people in Boston, if I've got the number right, seem to be fairly strongly disposed to getting vaccinated. Is that good enough?
Well, the epidemiologists are kind of all over the map on this, and it seems as though most epidemiologists say that somewhere around 70 to 80% coverage in a population will result in enough herd immunity to prevent it from spreading, at least spreading rapidly, like we have had these surges over the past year. So it seems as though 80% might be okay, but the problem is that 80% might be 100% in Newton, but 60% in, I don't know, Mattapan or something, right? So, and that's a concern, because we certainly want to make sure that it's spread across the communities, especially communities, immigrant communities, low-income communities, where there's a lot of concern about this, and a lot of justified concern, to be quite fair to the folks that are saying maybe we should wait. And that's because of what the government and various private institutions have done to people of color over the years regarding their role in studies, like Tuskegee, for instance. So I would say that the most important thing we can do with regard to that is we have lots of people of color that are in the healthcare system. In fact, they're really important in the healthcare system. They've run parts of the healthcare system. They've been part of developing the vaccine, and they are getting vaccinated. And having great public relations campaigns that show people of color that, look, this is something that's about safety in your community, safety for your family, is something that probably would, I would guess, win over a lot more people that are a little bit hesitant to get that done.
Well, one problem we're encountering right now, even with just the access to the vaccine for people age 75 and older. You've got an older population, so even if they don't have a language barrier at issue, they might not have an internet connection. They might not have a lot of dexterity on a mobile phone. They might not have a smartphone at all. What about helping those people get their shots?
I don't know anybody in 65 and over, and actually, and especially people 75 and over, that isn't incredibly frustrated with the fact that they all have friends or neighbors or family members or whatever that have gotten vaccines in other states, that they're already set up. And so the frustration level is enormous in that population. So, the question is, well, how did that happen, right? So, so I kind of 3 points that, one of which I made, which is that we need to work backwards from how we going to accomplish this. Another thing is flexibility and being able to make sure that we get the shots into as many arms as possible, as quickly as possible. And the third area is alternative systems for people. I'm every place I've ever worked, I've always played the customer and like make sure, to make telephone calls to your own system, make sure that they work. And I remember, one job that I had, I actually called up. It was an organization that was really inefficient in terms of primary care. And I called up and just tried to get an appointment and found out that none of the doctors were taking new patients. And I was like, whoa, what's going on here? It astonishes me that we didn't test this system out sufficiently so that we have so many people over the age of 75 that are frustrated right now, including friends of mine who are calling me and saying, Bill, what the hell's going on? So I think that we should have anticipated this and created alternative systems for 75-year-old people who don't really have good computer access or don't really know how to click on a link and stuff like that. But even people that know that and are very savvy at computers are having difficulty with the system. So we should have organized that. We're Massachusetts. Massachusetts has a lot of smart people, and especially in technology. And somebody should have, made a phone call and said, test this system and make sure it's foolproof. But in case we have people that can't use it or whatever, that we have this alternative system. And I noticed that the governor said, how more accessible do you want to be? Well, you can be a lot more accessible, obviously, because we have a lot of people complaining.
Well, thank you very much for sharing the complaints with us, and hope you stay healthy there, Bill.
Thank you, Chris. Happy to be on.
That was Bill Walczak, a contributor to the Dorchester Reporter and a longtime leader in community health in the city of Boston. We'll have more news in just a moment.